locations. So patient-centered care, where the rubber meets the road, community-inclusive interventions to achieve equity in cancer care with Samuel Cykert, MD, and Christina Yongue, MPH, MCHES. And so let's find out a little bit more about our presenters. We've got a detailed bio on Dr. Cykert, and so feel free to look that over. But to make it a little more fun, we're going to find out our top 3 facts. And number 1 is, has the joy of teaching UNC and other healthcare-related students for 3 decades. And number 2 is part of the Greensboro Health Disparities Collaborative for 20 years. And number 1 has a 1-year-old grandchild named Samuel. Dr. Cykert, welcome. Thank you so much for being here.
Thanks, my pleasure.
Christina, again, we've got information about Christina Yongue, MPH, MCHES. And top 3, she began her collegiate journey at Florida A&M University, where she studied pharmacy. One of her 2 daughters is a cheerleader, and the other is a pianist. And number 1, one of her favorite memories with her mother was dancing to a Junkanoo band, or with a Junkanoo band in the Bahamas for her mother's birthday. Christina, welcome.
Glad to be here.
We are thrilled to have you both. I mentioned we'll use poll everywhere. Here's a screenshot of that first question. ACCURE stands for Accountability for Cancer Care Through Undoing Racism and Equity. And so true or false, we try to make this first one a softball. So you can think about that, and you should be able to go ahead and answer that in just a moment. Meanwhile, I'll flash our disclosure statement up there. Feel free to go back in the recording and read it in depth if you care to. All right, and we're already getting those answers coming in. We'll wait a few more seconds, but I see a trend developing here. How are they doing so far?
Brilliant.
Good.
Terrific. We were kind of hoping they might know that, so that's great. And without further ado, where the rubber meets the road, community-inclusive interventions to achieve equity in cancer care. And Christina, I'll turn it over to you.
Thank you so much. Thank you all for being here with us this afternoon. So we're going to get started and share with you more about our story. And so we're starting to set the context of where we're beginning this in Greensboro, North Carolina. And as we get into telling you about the pictures that you're seeing on your screen, I always like to begin by acknowledging that I'm not here by myself, that I joined the Greensboro Health Disparities Collaborative, which we will introduce to you as a result of meeting Mama Nettie Code, and I'm going to tell you who she is. She's in the ancestor realm, and also as a result of my relationship with my mother, who I danced with at a Junkanoo band, but she passed away from breast cancer, and she's in the ancestor realm. And so I'm bringing that up because I'm not here by myself. We're not here by ourselves, and that I'm coming here in respect and honor of them. And so going forward, here on our screen, again, more ancestors. Dr. George Simpkins here is a dentist in Greensboro in the 60s, where he initiated a lawsuit to integrate the hospital system. So in Greensboro is where you see the historic marker has been placed, that it was here, and this is the picture of the Moses Cone Hospital at that time, where one of Dr. George Simpkins' patients could not be seen because of the color of their skin. And so he had to take on a lawsuit to push for the integration of hospitals at that time for the health of his patient. And so it was successful after, not just easily, but these are the grassroots organizers that we have to stand on the shoulders upon in Greensboro. So the marker reads, the landmark federal court of appeals decision in 1963 involving Cone Health Hospitals or Cone Hospitals led to the racial integration of hospitals in the United States. So because of the work of Greensboro community activists, the physicians, the Black physicians in the time, pushing for integration so that all patients can get equal care and quality care, led to the integration, because it was in 1964 when nationally the Civil Rights Act was passed. But we want to set that context of we are coming from Greensboro doing this work. Okay. And so coming forward, we had some more community activists to decide we want to define what is happening to our communities for ourselves. Why are we still continuing to see unequal experiences between the people in the Black community, the people in the white community, even still going forward into the current time that we are today? And so in defining the problem, you see a picture there of Nettie Code and Mr. Barton Parks. They were two members of the Greensboro community who were activists, who were trying to wrestle with these issues of racial inequities that still remain and what can be done about that. And so Mama Nettie Code was a lifelong community activist in the Old Ashboro neighborhood of Greensboro, in the southeast area of Greensboro. And she wanted to do more along with her allies and partners. And so as they were beginning to talk about what can we do to improve equity in our communities, this report, the Unequal Treatment Report, came out from the Institute of Medicine. And we're almost at 20 years celebrating the Unequal Treatment Report's phenomenal moment of announcing. And I'm going to read to you what was quoted in the Unequal Treatment Report. It said that evidence of racial and ethnic disparities in healthcare is, with few exceptions, remarkably consistent across a range of illnesses and healthcare services. These disparities are associated with socioeconomic differences and tend to diminish significantly, and in a few cases, disappear altogether when socioeconomic factors are controlled. So when we start, so this was making a distinction about the connection between race and the experience that people were having in their healthcare services. And it further goes into, it's an entire book, and it further goes in to say, even when you control for access to healthcare, I'm gonna say that one more time. Even when we control for access to healthcare, there are still differences by race when people from different racial and ethnic identities go through a healthcare institution. So that means that there's something happening inside of the healthcare institution, even when people have access. And that is a critical piece of evidence that the community organizers in Greensboro use to continue to do something about this. And I also wanted to point out again that these were community leaders, okay? Community organizers. And so let me go forward. Here you will see the picture of how the community organizers brought together a group of people to do something about it. The Greensboro Health Disparities Collaborative. This is a picture of kind of our progression over different years, and then our mission statement. And so our mission says that we will establish structures and processes that respond to, empower, and facilitate communities in defining and resolving issues related to disparities in health. So each word is very important. Processes, respond to, facilitate, defining for ourselves, and resolving them. And so the community organizers went about interviewing academic investigators, medical staff, other community organizers, and bringing them to the table. And this happened with an 18-month planning grant by the Moses Cone Foundation. At the time, it was labeled. And that's I'm smiling because of the progress of that. So you heard me say we started with having the Black community to sue to get integration. Coming forward, having the seed funding to develop a coalition that will do something about that. And then having that being started with the community, because we're going to be talking about community involvement all along the way. So that was significant in our unique beginnings. And you see the diversity of our members here, not only by racial diversity, but also by age and gender. And there's different disciplines, and I know you can't see all of that, but the disciplines that people come from, whether they were educators in the K through 12 school system and retired, or they're student interns in a public health program or in a medical program, or postdoctorate students, or again, medical providers and medical administrators. all coming together to do this work and being invited to the table by community initiation. Okay. And so the requirement to do something about the problems that we're seeing, the inequities that have persisted, that the unequal treatment report established, is that we have to understand what caused those inequities, what caused the racial inequities. And so several of the members had started been invited to go to the Undoing Racism training out of New Orleans, Louisiana, by the People's Institute for Survival and Beyond. And then what they found out was a way to understand what is racism, okay? So here on this slide is some of the way that we unpack the term racism. And it's very important that we have the same understanding and a common language so that we can be addressing how to change it and undo it. And so we learned that social economic status alone does not explain away racial inequity, and that racism equals race prejudice plus social and institutional power. Power meaning you're a decision maker in these institutions, plus having racial prejudice results in racism. And another way, institutional racism is a process of oppression, unconscious or not, so it could not be intended, functioning as a system of structuring opportunities based on race that unfairly disadvantages some, unfairly advantages others, and undermines the potential of the whole society. So when that is in place, as it has been historically in our country, and if somebody is not doing something actively about it, it's still in place today, this is what we are trying to change. And then if racism can be created, then it can be undone, because that is what we are aiming for. So these are the things that were learned in the Undoing Racism training, which is a 2-day intensive, deeper dive into these concepts. And it takes that much time to unpack all of this. In addition to the People's Institute for Survival and Beyond, there's also the Racial Equity Institute, which is based in Greensboro as well, and has delivered the training for our organization as well. All members who come to the Greensboro Health Disparities Collaborative are required to attend this training, again, because it sets up the baseline for what we're doing. And so when we started, I was not a founding member, but I joined in 2007 as the project coordinator for the first exploratory research study that the collaborative undertook. And they were focusing on breast cancer. We'll get into some of that more. But as everybody is required to go through this training, it introduces concepts and strategies related to community organizing and systems change, while also fostering building through various activities. It challenges participants to analyze structures of power and privilege that hinder social equity, and provides a historical and institutional understanding of and shared definition of racism. It prepares participants to be effective organizers for justice. And so having this common understanding about race and racism allowed our collaborative members to be more open to one another, so that we didn't feel like we had to be politically correct, but we could talk clearly and directly about the issues that we are discussing. And so it strengthens our understanding with one another, and it makes it easier to talk about these issues of race and ethnic difference. It is different than cultural competent care. We want to be clear about that. Cultural competent care is intended to raise an individual's awareness about racial and ethnic disparities, but it does not move us by only raising somebody's awareness about people's cultures does not move us towards assessing and addressing the stark realities of inequities in our healthcare system, or for gaining tools to combat inequities at the systems level, okay? And this is what our training of all the collaborative members allowed us to think about the systems level. And so this is how we address the issues. I'm gonna go ahead and invite Dr. Sam Cykert to take us to the next slide.
Yeah, so I was a founding member of the collaborative, and in the early deliberations, we went through the training as Christina described, and as a white guy in the medical establishment, it really wasn't easy. But because you focus on this idea of power and institutions with systematic trends, but think about it a minute. And we went over this data at the beginning of the collaborative, but think about it a minute. There are now 50 years of data controlled for health insurance, socioeconomic status, comorbid illness, age, and yet there are these consistent trends of people of color having worse health outcomes. Today, we're focusing on cancer. And at the time, the collaborative, despite all the data we went through, the focus was on cancer. And the reason for that is that was in the early 2000s, the NIH wanted to whip the big C, cancer, and nobody cared about chronic disease, even though, it was a 20-year time horizon, and people just weren't funding a lot of chronic disease work at that time. But with the combination of data and stories of individuals who had experienced medical care that they weren't comfortable with, that wasn't standard. After we put all this together, it was decided that breast cancer was important because we had many collaborative members who themselves or had family members affected by breast cancer morbidity and mortality. And though we wanted to make sure that men were considered as well, and the number one killer of men was and still is lung cancer, and to this very day, Black men die of lung cancer 20% more than any other group. And so all those things contributed to deciding where are we going to do this work. Think about that a minute. 50 years of data. And when you look at the curve, okay, this is breast cancer deaths. The blue line are deaths of Black women, which are higher than white women, even though there's a higher prevalence of breast cancer in white women. And back in the mid-70s, death rates were equal. And that's because back in the mid-70s, diagnosis was lousy and treatment was lousy. And so there was no advantage to be gained by early diagnosis or aggressive, sophisticated treatment. But as time has gone on, as you can see, getting into the 2020s here, mortality in breast cancer is going down considerably, but the gap in death for Black women is actually expanding. And as we do biologic diagnosis markers and biologic treatments, really the miracles of modern medicine and genetic medicine, Black women aren't getting the advantages of that at the same level of white women. And I want to emphasize again, all these data are controlled for socioeconomic status, insurance, age, and comorbid illness. So it's funny. I've given this talk, and Christina as well. We've given this talk across the country, and I try to say 4 or 5 times we've controlled for all these things, and yet the first question is, don't you think it's socioeconomic status? Not entirely, okay? Not entirely. So that's the breast cancer story. And the lung cancer story is similar. So these data apply to curable non-small cell lung cancer, stage 1 and stage 2. people who get surgery and people who survive. And despite the fact that you have an illness that is invariably fatal in 4 to 5 years without treatment, 50% fatal in 1 year, despite all that, there's still this 10 to 15% gap in treatment between black and white. And another thing I want to emphasize today is most of our focus today is on black versus white data. There are differences between white and other races, but historically, black patients and Native Americans have had the worst outcomes even beyond other groups of people of color. And so we're taking, the most extreme and most egregious example, and we're trying to show that, yes, there is a solution to this. And again, this is another lung cancer slide. The upper graphs are black and white people who have surgery. The bottom is people who don't. So those who say there's some kind of genetic thing going on here, forget it. It's, do you get treated or not? Okay, that's what determines whether or not you live or die. And in healthcare, we can fix it so there's no difference in treatment. That's one thing we can control. You can't control all social policy. You can't control all the social determinants of health, but you can control whether or not someone gets medical treatment.
All right, and here's that first poll everywhere question. First real one, and these are all anonymous, by the way. As breast cancer mortality falls, the excess mortality for black patients is also falling. So true or false? Take about 10 to 15 seconds to answer that, if you would, please. All right, and we're definitely trending in one direction. How are they doing?
Doing great. Mortality in both groups is falling, but not as well in black women as white women.
And so with these problems that we have identified, and I want to come back to the first exploratory study where the collaborative documented differences between black women and white women, to Sam's point, we had to, again, think differently. What can be done differently about addressing these long-term patterns of racial disparities that are longstanding? And so, we continue to enhance our understanding about the problems. With the Racial Equity Institute, several members have been introduced to the concept of the groundwater approach. And I want to refer you to their website so that you can find out more about that. But I want to take a minute to just explain to you the concept here and how that helped us to think about undoing the problem of racism, institutional racism. Is that when you have one individual, if you see one fish that is swimming in a lake and that fish dies, then you would think about what happened with that one fish. Was it something in their organs? What organ breakdown happened in that one fish? Let's try to work on other fish's organs to make sure they don't continue to have this problem. But when you have an entire lake and a larger number of fish that all look the same are coming up dying in a higher proportion than another body of fish in that lake, then you start to look at the lake. What is it about this environment that these fish, who all have the same organs, are swimming in? What is it about something in the environment of the lake that caused that? And beyond the lake, underneath the lake, the groundwater, is it spilling over into other bodies of water too? That's something you might wonder. And so this is where we start to unpack and address what can be done about the problem. Again, this is a similar quote about if it was created in these institutions historically, how, and it was maintained that way, how can we undo that? And so this is how we approach the solution. So with the Greensboro Health Disparities Collaborative, through an intervention-based research project called ACCURE, that stands for Accountability for Cancer Care Through Undoing Racism, we used a racial equity analysis to help us with the solutions. So again, thinking about where are the body of people, thinking about the system level, not about the individual, not blaming them. What can be happening at the systems level? And part of addressing a system level pattern is that we need to use transparency. This is an anti-racism strategy for undoing racism. More transparency so that we can understand what's happening in real time to the patients in the institution. Accountability is another anti-racism racial equity strategy. Accountability, continuing to have it was not only that the Greensboro Health Disparities Collaborative was established and wrote these grant proposals with the National Institutes of Health funding it, and then they left, but staying in conversation on a monthly basis. We meet on a monthly basis to talk about what's happening each step along the way. And a part, in addition to the accountability, is using community-based participatory research approach so that together the community members, the medical providers, the academic researchers, and other community organizers together with accountability, we're talking about how is it going to be designed? How is it going to be carried out together? That accountability piece, and again, this is the community involvement, is what helped us to be successful, and we'll get to that. Also, enhanced communication. This is another racial equity strategy that people are not working in silos, just in their discipline within a medical institution, but we're having enhanced communication across disciplines. And so we use these principles to design an intervention that will bring about a change.
Yeah, and this is where we talk a lot about translational research. Well, it's the job of the scientists and healthcare people to translate what the community is talking about, the barriers that the community is talking about, into using the tools that we have in order to achieve these things. And so the first thing, in terms of real-time transparency, now I told you studies had been done for 50 years showing these gaps in care and in outcomes. But the fact is, those studies used retrospective data that were years old. So by then, the horse is out of the barn. The patient's already dead. So by using all the digital data that we have around in real time to follow the good and the bad of how patients are progressing through care, I mean, the capability is there. And so what we did is, through electronic health record data, we were able to create a warning system that showed that if a patient missed an appointment, we knew it within 24 hours. And so a specially trained navigator could reach out to the patient, determine whether the barriers were typical or atypical, or whether it had to do with things that were particular to patients of color, such as communication problems, such as trust problems, such as ... past experiences with the healthcare system. Anyway, the barriers could be worked out and the navigator could bring the patient back into care. But the other thing we found out from other studies is that clinical inertia is an issue. In that sicker patients who are not like the caregiving physician, the physician isn't as comfortable taking risk. And so there tends to be delays in progressing with care over time. So the other thing we did is we worked with the clinical community to determine what good milestones of care would be. And so if a patient didn't reach an expected milestone in care, a warning would come up, and either the navigator or our physician champion would approach the clinical team and say, did you really mean for this delay to happen?
Mm-hmm. Okay. And so this next part, accountability, this intervention was to help clinical teams get the feedback on the situations where patients completed their treatment for cancer, breast cancer and lung cancer. This is a standard in quality improvement. However, it's not a standard that is broken down by race. And this is what was unique. One of the other unique things about our ACCURE research study is that we made sure that the clinical team could see the difference in cancer completion and treatment by race. So it allowed for another enhancement to quality improvements. And then also it allowed for something to be done about it. So to be addressed. All of these are, again, around accountability, transparency, and being addressed. We also,
Yeah, and I was just going to say, going back a little, this goes along with the transparency too, in that when one of those flags, we talked about some of this has to do with socioeconomic status, some of it doesn't. Some of it may have to do with implicit bias or other things that delay care. But whatever the cause, when a signal comes up and says, hey, things ain't happening, it triggers a caring human being of responsibility to do something about it. So if it's a socioeconomic problem, you address that. If it's one of these other problems, you address that. Whatever it is, you need the signal.
Yeah. And while that's going on in our intervention, we also had a parallel intervention called the Healthcare Equity Education and Training Sessions. This was different from cultural competency. Cultural competency may be, and I know there's various forms of it out there, maybe just exposing people to other people's cultures. Whereas in this series, what made it different is a series of 8 sessions. We are using transparent data, using the data at the institutions where this intervention is taking place, giving a presentation to an interdisciplinary team of providers to say, this is what's happening by race at your institution, and then also having some education around what else can be done about it while we are doing something about it simultaneously at the same time. So we also can share a link with you about where this has been published in a book chapter about the HEAT session. So I won't spend too much time on that. But let me go on to the next. And so another systems level intervention, as has been announced already before from Sam Cykert, that the ACCURE Navigator, the enhanced two-way communication, when an issue was flagged, a patient did not come in for a milestone appointment, then the ACCURE Navigator can do something about that, take action. The ACCURE Navigator was trained as a requirement of their job position to attend the 2 days of a racial equity training so that they can understand more about the history of barriers and mistrust, medical mistrust, and why is there implicit bias remaining. And so we continue to have them be prepared for that. They also had role plays, and then they also worked with physician champions. And this intervention enhanced communication and enhanced that for our interventions going on.
All right. Oops.
Sorry. You can go ahead. Yes.
Oh, okay. All right. Thanks. So here's this next poll everywhere question. System level interventions work better because A, institutional bias calls for widespread solutions, B, the problem is caused by a few bad apples. C, disparities are multifactorial, so a transparent signal is needed. D is A and C, or E is all of the above. And if you'll take 15, 20 seconds, again, this is all anonymous. Really appreciate all the folks who are jumping in and answering these questions. While we're waiting, I'll just mention I was looking through the names of the attendees, and it looks like we have some new attendees to the series today, so I do want to welcome them. All right, Sam and Christina, how are they doing?
Got it.
Great. And
right.
those, it's definitely a multifactorial problem, and if you can use multi-level solutions, then that's what works best for a multifactorial problem. So this is all good.
Yes.
All right. So in the studies, we were working with patients who either had highly probable or newly diagnosed curable breast or lung cancer, focusing on stages 1 and 2 for the purpose of the initial study. And patients were identified using electronic appointment data.
And so to recruit the patients into the research study, this is where, again, the community came in to be very helpful. We were able to work with the Sisters Network chapter in Greensboro, which is African American breast cancer survivors, and to center their stories to help us understand when they were first diagnosed with breast cancer, what was it like to start that journey, and then introduce and pilot test our recruitment script and conversation at one of their meetings, so that then we could be prepared to recruit people at the cancer sites. And then we also worked in collaboration with the healthcare administration on the workflow during the day. And so those combination of ways to include community members, these are pictures from a Sisters Network meeting where we were discussing what can be done to make sure that we involve African-American Black patients into this clinical trial, because we know historically there's a lot of mistrust with research. And so we wanted to be very careful in that. And so this is an important way we included community. And additionally, to help with recruitment, we had a one-page statement that went over the entire research study. We trained our nurse navigators in helping with the recruitment. And so you see the one-page info sheet there and how people would receive compensation for participating in interviews following the study, and then how to identify who was eligible is in that slide. And then, go back here. During the recruitment process, we still continue that accountability conversation at community meetings with the Greensboro Health Disparities Collaborative, where people ask from an anti-racism lens, why are people not joining the study? What is it that we can do? And so all those conversations helped with making sure we exceeded our goals with recruitment. And so here is the example of where our goals were on recruitment: 108 Black participants. We recruited 122. For white patients, 162 was the goal. We recruited 205. And so we attribute that to the efforts it took at the beginning on the front end to make sure that we are building trust into the process of recruiting patients into a clinical trial.
And getting 92% of Black patients approach, I mean, it's almost unheard of, right? I mean, that number alone shows you how effective the community involvement was.
Yep.
All right, well, this a quick story. So we didn't think with all the electronic data available, we didn't think it was ethical to do a randomized control study on this. So we did a retrospective control group. And remember, as I told you at the beginning, these treatment data had been flat for 3 decades, okay? And nothing had changed at any of these institutions for decades. And yet we knew that in the medical literature, we would be criticized that, oh, this is a secular trend if things got better. It just got better over time. So we made sure we had a concurrent control group too. And so there were 2 studies. The ACCURE study itself, it was curable breast and lung cancer. And 2 cancer centers were involved. And note, we always like to get a center from the north so that when you publish this stuff nationally, they don't say, oh, this is a Southern thing. Well, I'll tell you, it ain't a Southern thing. This is an American thing. And so at baseline, you can see there was about a 7.5% gap between white patients and Black patients completing their care with the ACCURE intervention, transparency, accountability, enhanced communication, real-time registry, race-specific QI, and a navigator. With those things combined, care got better for everyone, and it was nearly equal. And in the secular trend concurrent group, the gap was still 7%. And I'm not going to go into the multivariate analysis in detail. I know this slide is busy, but in controlling for insurance, socioeconomic status, comorbid illness, site of treatment, stage of disease, all the things that you would control for. What this slide shows you basically is that the Black intervention compared to best treatment in the end was equal. And if you look at the Black retrospective and the p-value there, that shows you before the intervention, things didn't go so well, that the odds ratio was only about half that a similar Black patient would complete their care. Then in the lung cancer alone study, there were 5 centers, again, 1 in the north. And at baseline, for completing care for curable lung cancer, there was a nearly 9% gap at the beginning. The odds ratio for a white patient completing treatment, for Black patient completing treatment compared to a white patient was only 0.66. And again, you can see all the things we controlled for in the multivariate analysis. The intervention group, care was almost perfect. It was almost perfect. And there was no racial difference. And we actually did a very sophisticated between group analysis so we could compare the Black intervention patients to the white retrospective patients, the Black intervention patients to the white concurrent patients, the white intervention patients to the white retrospective and white concurrent patients. Care got better for everybody. The white patients who went through this intervention got much better care than the white retrospective or white concurrent group. So this kind of approach works for everyone because it's a system-based, systematic intervention. And Christina actually presented this at the American Public Health Association, but people with breast cancer don't die as fast as people with lung cancer. But you can see the treatment difference here. This was in Greensboro before the intervention compared to Greensboro after the intervention. So there was a 2% statistically significant difference in death for Black patients. in breast cancer, 7% in lung cancer. And then in the after intervention groups, you can see the differences in death went away. And not only did the differences in death go away, but everybody lived more. What more can you ask for? Isn't that good?
Yes, 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 yes.
And then recently, there have been new data that have come out regarding time to treatment, especially for lung cancer. And if you look at time from diagnosis to treatment, if you get over 8 weeks in lung cancer, death rates start going up. And so back in the retrospective group and the concurrent group of our studies, you can see that there was a big difference between the percent of Black patients who got to treatment early compared to white patients. And I guess you can see my arrow there. And also in the average time to treatment. So Black treatment time in the intervention went from 43 days to 28 days, and 87% got treatment within 8 weeks, whereas white went from 32 days to 21 days and 75 to 85% within the 8-week mark. It helped everybody. It helped everybody.
Yes.
All right, and here's our last question. The ACCURE intervention, A, took advantage of community partnership and insights. B, reduces disparities and improves treatment for all. C, points out the importance of measuring care, particularly among disadvantaged groups. D is A and B, or E is all of the above. And so take 10, 15 more seconds, and then in just a moment, we'll go ahead and move it to the Q&A section. So if you've been thinking about questions that you'd like to ask our presenters, you'll be able to start submitting those in just a moment.
All right. And appreciate everyone getting the hang of all that.
Yes.
Thank you.
Yes, thank you. And so the moral to this story, because I look forward to your questions, to remedy systemic institutional level racism, 1, you have to work with the affected communities through a systemic level racism lens to determine appropriate outcomes and measures for the intervention. 2, you must measure the outcomes according to race, or if you're comparing another racial disparity or other identity population, use that when you're measuring your changes. 3, apply interventions in real time. That's including transparency and accountability. And then 4, with a system-based intervention advised by the community, care can be improved for everyone.
Yeah, and one thing you must be thinking of is God, this must have cost so much money. It must be so expensive. Well, the fact of the matter is, to build the real-time warning system, the real-time registry, the upfront cost was a nine months of a full-time programmer and benefits, which amounts to about $100,000. And the other cost was that we had a few meetings with community clinicians to help us determine the best care protocols we were programming for and the timing of the milestones we were programming for. And so you're talking about $100,000 and then about $10,000 a year to make sure you're maintaining the system. Think of all the money we spend in medicine. And the other thing was, with the increase in survival, dead people don't pay for their medicine. Their insurances don't pay for their medicine. So that $100,000 is probably a bit of a wash when you think of the future. And then in terms of navigation, now we did navigate everyone in the study, and you may not be able to afford to navigate everyone. And so there needs to be a bit of a risk stratification system that you need to develop and make sure the patients at most risk get navigation, whereas people who naturally go through the progression of care don't. But that's a determining factor. But everybody's going to navigators these days. It's a matter of who they navigate, how they navigate, and how are they trained. And that difference doesn't cost much. So we're done, okay?
All right, and let me go ahead and bring it up to that next slide, and I'll be watching for those questions. While we're waiting for those to come in, let me ask, what's next? This is phenomenal, and thinking about, with the UNC Lineberger Cancer Network framework, thinking about of cancer and the catchment area of North Carolina, what would you like to see happen, or what are you aware of that already is happening in terms of building on this amazing research?
Yeah, well, first, Cone Health, one of the participants in the study, they've built this into their EPIC system, and their navigation leader was the chief navigator from the ACCURE study. So Cone Health is actually implementing this. At UNC, Sharon Bigelow is one of the folks working on a new patient-centered navigation program for UNC. And she and her group are very aware of this, and they're starting to build. And we're having some of the meetings with informatics folks to start thinking about doing this at UNC at the Basnight Cancer Hospital. New name there. I have to get in there. New name. The NC I actually met Mark Basnight, who's a good guy. But anyway,
absolutely. And funny. Oh, I'm sorry, Christina, go ahead.
In addition to implementing it and institutionalizing it in one setting, there is a new research study called ACCURE for Moms, where it's led by the principal investigators, Jen Tang and Rachel Euresha. And they're investigating how can these interventions be used across North Carolina for the maternal and infant mortality, racial disparities. And so this is another next step that's happening.
Yeah. And we've also done all of this in a large cardiovascular study called Heart Health Now. And hey, it works for reducing cardiovascular risk too. And it's not just cancer. And think about it a minute. You're talking about a system where you know where there are problems getting optimal health outcomes. You account for it for the people that are most disadvantaged, and then you have a caring human being who's intervening to help implement what's missing. That can work in a lot of things.
Yeah, no, that it comes to mind that this scales extremely well, I would imagine. We always think about scaling. Does something not only work, but does it scale? And it sounds like it really does. Yeah, Sam, you mentioned Sharon Bigelow, who in fact had a comment on the chat. Thank you, Sam and Christina, for your work. The UNC Health Center Care Navigation Program is integrating the ACCURE research into our navigation practice, including EPIC technology upgrades, triggers, and DEI training. And then we are still waiting for questions. We have a few more minutes if anyone wants to go ahead and polev.com/UNCLCN. I do see one in the chat. What did the specialist actually do to get people in and or keep their appointments?
And so this is where our nurse navigators, they're training in knowing the barriers, the historical barriers that patients face. They had to integrate understanding of why was mistrust happening, why were patients not showing up, and then do an additional outreach method, and also asking for the patients to teach back to them how do they understand what else is to come in their treatment completion journey. And so it's a combination of a lot of things that the nurse navigators had to do to keep people coming back. but it started with their inquiry. And also, I want to refer to the Kleinman model, where the nurse navigator had to assess how does the patient, again, understand what's going on with them, so that once they get those answers from that conversation, then the nurse navigator can go about things to help solve the problems, whether that's advocating with the physician champion that the schedules need to be shifted because this person is working double shifts. Their support system is coming in from Atlanta. We need to change something to accommodate for that. So it's a variety of strategies, but one key part is that we had a physician champion in place, the nurse navigator in place to collaborate when it's identified what those barriers are. So
that's great. And I see, Christina, you put a link in the chat to greensborohealth.org/publications.html for information about the work. It is 12:59. We're nearing the hour, so we'll go ahead and just make a few closing remarks here. I do want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank the team, Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Patrick Muscarella for all of their hard work behind the scenes to make this and other series possible.